Good morning, everyone. Welcome. Today, we are going to tackle a very important topic from pharmacology, and that is anticoagulants. Now, these are some really powerful drugs, and I guarantee you understanding them properly is going to be absolutely essential for your clinical practice. So, let's get started, shall we? Okay, before we even talk about any drugs, let's start with a simple question. Just think about it. Our blood has everything it needs to form a clot, right? All the factors are just floating around, so why doesn't it just solidify inside our blood vessels? What stops it? You see, it's a beautiful, delicate balance, isn't it? And understanding this balance is the first step to understanding the drugs that we are about to discuss, the drugs that we use to intentionally tip this balance. So, what exactly are these anticoagulants? Well, in simple terms, they are drugs that make the blood less likely to clot. Now, this next point is absolutely crucial. Please remember this. They do not dissolve clots that have already formed. They are not clot busters. Okay? That is a totally different group of drugs. What they do is prevention. They either stop a new clot from forming or they stop a small clot from getting any bigger. Now, to understand this whole chapter, you need a simple framework, a skeleton to build on. And luckily, it's very, very simple. We divide all the anticoagulants into just two main teams. It's based on how we give them to the patient. Team 1 is parenteral, which means by injection, and Team 2 is oral, which means a tablet you take by mouth. This is the most important classification, the first thing you need to know. All right, now look at this slide. This chart, this is your entire chapter on one single page. You see the main division, parenteral on one side, oral on the other. And then below them, you see more branches. I know, it might look a little bit intimidating, but don't worry. We are going to go through each and every branch one by one, step by step. So let's begin with the first team, the parenteral agents. So the parenteral anticoagulants. I like to call them the fast responders. Think of them as the emergency team. These are the drugs we use in acute situations, in the hospital, when we need to stop the clotting process immediately. Because we are injecting them directly into the body, either into the vein or under the skin, they start working very, very fast. And who is the captain of this team? Well, it's the big boss, heparin, such a famous drug. And a little fun fact for you, it was discovered way back in 1916 by a medical student just like you. Heparin is our prototype parenteral anticoagulant. Its action is very powerful, and if you give it intravenously, it is instantaneous. It's the original and still one of the most important drugs we have. So how does this big boss work? Well, what's fascinating is that heparin is an indirect actor. On its own, it doesn't do much. What it does is it finds our body's own natural anticoagulant, a protein called antithrombin 3, or AT3. Heparin binds to it and, well, it supercharges it. It makes it 1,000 times more powerful. And this superactivated complex then goes and rapidly inactivates the main clotting factors, especially factor 10A and thrombin. So you see, heparin is like a coach, making our own player much, much better. Now, in the heparin family, we have two main members. Think of it like a father and a son. The father is unfractionated heparin, or UFH. This is the original, the classic, the big molecule. And the son is the newer, smarter, smaller version, called low molecular weight heparin, or LMWH. You might have heard of drugs like enoxaparin. Understanding the difference between these two is a very, very common exam question. So why do we often prefer the son, the LMWH, these days? Well, the advantages are quite significant. First, it gets absorbed much better from under the skin. Second, its action is longer and more predictable, so you can often give just one dose a day. And third, and this is a huge advantage in the clinic, you don't need to do constant blood tests to monitor its effect. With the old UHF, you have to keep checking the APTT. And finally, the risk of osteoporosis with long-term use is lower. So all in all, it's just much more convenient. Of course, every coin has two sides. A powerful drug will have powerful side effects. The most obvious and most serious risk with any anticoagulant is, of course, bleeding. That's a no-brainer. But there is a very peculiar and dangerous side effect of heparin that you must remember for your exams. It's called HIT, or heparin-induced thrombocytopenia. It's a strange condition where the platelet count actually falls. Then there's osteoporosis with long-term use, and sometimes allergic reactions. This is the price you pay for its fast and powerful action. All right, so that was our fast-acting injection team. Now let's switch gears completely. Let's move on to our second major group, the oral anticoagulants. These are the long-term players. These are the tablets that patients take at home for maintenance, sometimes for weeks, months, or even for the rest of their lives. And the undisputed king of this category, the classic, is warfarin, an old, very reliable, but also very tricky drug. And here is a fun fact for you, so you will never forget it. Warfarin was actually first used as a poison to kill rats. It would cause them to have fatal bleeding. It was only much later that scientists figured out how to use this powerful effect in a controlled way to help humans. Imagine that. Now, listen carefully. Here is a fundamental difference between heparin and warfarin. Warfarin acts indirectly and only in vivo. What does that mean? It means if you take a test tube full of blood and you add warfarin to it, absolutely nothing will happen. The blood will clot just fine. Why? Because warfarin doesn't attack the clotting factors that are already in the blood. No, it goes to the factory, the liver, and it stops the production of new clotting factors. So the next logical question in your mind should be, okay, professor, so how does it do that? How does warfarin go to the liver and tell it, hey, stop making functional clotting factors? It's a good question. So let's look at the mechanism. This picture explains it perfectly. You see, for the liver to make certain clotting factors, specifically factors 2, 7, 9, and 10, it needs vitamin K. But it needs the active form of vitamin K. Now, after vitamin K does its job, it becomes inactive. There's an enzyme in the liver called vitamin K epoxide reductase whose only job is to recycle this inactive vitamin K and make it active again. And what warfarin does is it very cleverly blocks this enzyme. So no recycling, no active vitamin K. And if there is no active vitamin K, the liver cannot make new, functional clotting factors. It's really quite brilliant. Now, think about this. Since warfarin only stops the production of new factors, its action is not immediate, right? The factory is closed, but the soldiers who were already on the battlefield, they are still there. The body has to first use up all the clotting factors that were already circulating in the blood, and as you can see, this takes time because each factor has a different half-life. The full effect of warfarin is only seen after 2 or 3 days. This delay is a classic feature of warfarin. And this brings us to the many challenges of using warfarin. As we just saw, its action is slow. It also has a very narrow therapeutic window, which means the gap between a useful dose and a dangerous dose is very small. Because of this, you have to constantly monitor the patient's blood with a test called the INR. It also interacts with hundreds of other drugs and even foods like green leafy vegetables. And most importantly, it is a teratogen. It can cause birth defects, so it is absolutely forbidden in pregnancy. So, because of all these problems with warfarin, scientists were looking for better, safer, easier alternatives. And that brings us to the new guys on the block, the DOACs. That stands for direct oral anticoagulants. These are the modern drugs, the solution to many of warfarin's old problems. And what a solution they are. Just look at the advantages. Remember warfarin was slow? These have a rapid onset. Remember the constant need for INR tests? With these, you don't need any monitoring. You can give a fixed dose. Remember all those drug and food interactions? These have far, far fewer. And their effect wears off much faster if you need to stop them. They have really changed the game. Okay, before we finish, let's have one final showdown. This is the classic comparison, the one you will be asked about again and again in your exams. Heparin versus warfarin. If you understand the differences between these two, you have understood the core of this topic. Let's just quickly go through this table. Route, injection versus tablet, onset, immediate versus delayed, activity, heparin works inside the body and in a test tube, warfarin only works inside the body. Mechanism, heparin blocks the existing factors, warfarin stops the factory from making new ones, and finally the antidotes are different. For heparin, it is protamine sulfate. For warfarin, you give vitamin K. This table is a perfect summary. So, to summarize the whole lecture, if your brain is feeling full and you can only remember 5 things, please remember these 5 high-yield points. 1. Anticoagulants prevent, they do not dissolve. 2. Heparin is parenteral, fast for emergencies. 3. Warfarin is oral, slow for long-term maintenance. 4. The new LMW heparins are much more convenient than the old UFH. And 5. Warfarin needs regular INR monitoring, but the new DOACs do not. This is the core of the chapter. And I will leave you with one final thought. A question for you, the future doctors. We have these amazing new drugs, the DOACs. They are so easy to use, so convenient. But they are also very, very expensive. Warfarin, on the other hand, is extremely cheap, and when we use it correctly, it's very effective. So the big question is, especially in a country like India, is the era of warfarin really over? Or does this cheap old drug still have a very important role to play? That is something for you to think about. Namaste, everyone. Welcome back. So today we're going to tackle a super important topic, something that is at the heart of so many medical emergencies, and that's the pharmacology of clotting. Right. This is Chapter 45, Part 2. Let's get straight into it.
Okay, so I want you to picture this. You're in the emergency department. A patient is rushed in. He's gasping for air, clutching his chest. In the very next cubicle, there's another patient. Can't speak, one side of their face is drooping, their body totally limp. A heart attack, an ischemic stroke. What's the common culprit here, guys? You guessed it. Often, it's just a single tiny blood clot, but in the absolute wrong place. And today, we're going to talk about the drugs that fight back. This is the real battle in your blood, and this is where pharmacology literally becomes a life-saving science. All right, so first up, let's talk about the big guns, the clot busters. These are the drugs we call in when a clot has already formed and is causing, absolute chaos inside the body. Think of them as the bomb squad, yeah? Let's go. So the technical term for these are fibrinolytic drugs, or thrombolytics. Their job is simple. Literally, lyse, or break down existing thrombi. The goal? Recanalize that blocked blood vessel and restore blood flow fast. Now, please remember, these are not for prevention. No, these are emergency drugs, the heroes that can save a heart or a brain from permanent damage. Okay, Beta, now look at this diagram very carefully. This picture, this tells you the whole story. See, your body has its own natural system to dissolve clots. There's this thing called plasminogen, which gets converted into plasmin, and it's this plasmin, think of it like Pac-Man, that goes and chomps up the fibrin clot. So what do our drugs do? Well, our fibrinolytic drugs are activators. They act like rocket fuel for this process. They just supercharge that conversion of plasminogen to plasmin. Simple, right? Now this table is really cool. It shows the evolution of these drugs. Just look at the last column, administration. Alteplase, the older one, needs a 90-minute IV infusion. Think about that, 90 minutes. Then came Reachaplase, a bit better, just 2 quick IV injections. But now, look at Tenecteplase, 1 single IV bolus. Push, done. Can you imagine the difference that makes in a chaotic emergency room or in a moving ambulance? This is a game changer. The key thing here is how much easier and faster administration has become.
So when do we actually use these powerful clawbusters? Well, for a big heart attack, what we call a STEMI, for a massive life-threatening pulmonary embolism, and, very importantly, for an acute ischemic stroke. But look closely at the stroke part. You have a tiny window, just 3 to 4.5 hours from when the symptoms started. We always say time is brain or time is muscle. That golden hour is everything. The sooner you act, the more you save. Okay, so these drugs are powerful. But what happens if they work too well? Or what if you give it to a patient and they start bleeding somewhere else? It's like having a car with a powerful accelerator but no brakes, right? You need a way to stop it. And that brings us to our next class of agents. And here, my friends, is one of the classic balancing acts in all of medicine. On one hand, you have fibrinolysis. You're breaking down clots, but the risk is bleeding. On the other hand, you have antifibrinolysis. You're trying to preserve clots to stop bleeding, but the risk is, well, more clots. Walking this tightrope, finding that perfect balance for your patient, that's the real art of being a doctor. So, let's go back to our battlefield diagram. You see the inhibitors down there? That's what we're talking about now. These are the antifibrinolytic drugs. What they do is they block plasminogen from even binding to the fibrin, so it can't get converted to plasmin. No plasmin, no clot busting. The clot is preserved. These are the drugs that slam on the brakes. Okay, for your exams and for your practice, you really need to know 2 main drugs here: epsilon aminocaproic acid, or EACA, and tranexamic acid. But honestly, the one you're going to see and use constantly is tranexamic acid. Why? Simple. It's about 7 times more potent. We use it all the time to control bleeding, after surgery, for hemophiliac patients, and importantly, as the specific antidote if you've given too much of a fibrinolytic drug. Excellent. Now, let's completely switch gears. So far, we've talked about destroying clots that have already formed. But what about preventing them from ever forming in the first place? For that, we have to look at a completely different battle and a different soldier in this war.
Okay, now please, everyone, pay close attention. This concept is absolutely crucial, not just for your exams, but for your entire clinical life. You see, not all clots are the same. Venous thrombi, they tend to form where blood flow is slow. They're rich in fibrin and red blood cells, so we call them red thrombus. We treat them with anticoagulants. But arterial thrombi, the ones causing heart attacks and strokes, they form in high flow areas. They are mostly made of platelets, so we call them white thrombus. See the difference? Different composition, different treatment. This is why we need a totally different class of drugs for arterial problems.
So, with that in mind, let's meet the drugs whose job it is to target these platelets, the ones that stop them from getting all sticky and clumping together. This is our army of prevention, the antiplatelet drugs.
And this chart here, it basically shows our different strategies, our different lines of attack against the platelet. We can block a pathway involving something called thromboxane. That's where aspirin comes in. Or we can block a specific receptor on the platelet called the P2Y12 receptor. Or, if we want to be really aggressive, we can block the final step of aggregation with something called a GPIB/3A antagonist. So you see, we have multiple ways to tackle this problem. Now, let's talk about good old aspirin. This drug is actually a bit of a pharmacological marvel. Here's the magic. When aspirin gets to a platelet, it irreversibly, and that's the key word, irreversibly acetylates an enzyme called COX-1. Now here's the kicker. Platelets don't have a nucleus, so they can't make any new enzyme. That platelet is basically knocked out for its entire lifespan, which is about 5 to 7 days. And this is why even a tiny, low dose of aspirin, just 75 to 150 milligrams, has such a powerful and long-lasting effect. It's brilliant, really.
All right, moving up a level. Let's talk about the P2Y12 inhibitors. The classic one, the one you've all heard of, is clopidogrel. But it's a prodrug, it's kind of slow to start working. Then came prasugrel, also a prodrug, but faster and more potent. And the newest player is ticagrelor. This one is cool because it's not a prodrug, it acts directly, and its effect is reversible. Now, very often, we use one of these with aspirin. That combination is called DAPT, dual antiplatelet therapy. This is the standard of care, for example, after someone gets a coronary stent. Why? Because you're attacking the platelet from 2 different angles. It's a much more powerful effect.
And finally, the big daddies of antiplatelet therapy, the glycoprotein 2B/3A antagonists. These drugs block the final common pathway of platelet aggregation. This is the last step where all the platelets stick together. So how effective are they? Well, they can inhibit more than 80% of platelet aggregation. Just think about that. They are without a doubt the most powerful antiplatelet drugs we have in our arsenal. So you see, we keep coming back to the same central theme, this delicate balance. The goal of all this therapy is to prevent a dangerous thrombosis, say in a coronary artery or after a stent is placed, but to do it with the absolute minimal risk of causing a bleed somewhere else. It's always about finding that sweet spot between preventing a clot and causing a hemorrhage. Okay, that was a lot. So let's try and put it all together now. Let's create a sort of battle plan. How do you choose the right tool for the job? This next slide is going to be your ultimate guide for that.
All right, guys, I want you to burn this table into your memory. Take a mental screenshot. This is your cheat sheet for the clinic, for the wards. It's simple. Fibrinolytics, their target is the fibrin clot. Their goal, bust existing clots. You use them for emergencies like MI and stroke. Antifibrinolytics, they target plasminogen. Their goal is to stabilize clots and control bleeding. In antiplatelets, they target platelets. Their goal is to prevent new clots, especially in the arteries. If you can remember this simple table, you will always know where to begin. And so, I'll leave you with this final thought. This constant balancing act between the power to dissolve a deadly clot and the risk of causing a catastrophic bleed, this is still one of the greatest challenges in medicine. Yes, our drugs are getting better, they're getting smarter, more targeted, but that fundamental challenge remains. So the question is, how will future drugs make this choice safer? That is a question for your generation of doctors to solve. Thank you, class.
Hello, bachcho, and welcome. Today's topic is super important. We're talking about hypolipidemic drugs. And believe me, this is something you're going to see every single day in your practice. Plus, it's a huge deal for your exams. So, let's get started, shall we?
Okay, so what's the plan for today? Simple. First, we'll get to know the enemy, cholesterol. Then we'll introduce our drug superheroes. We'll spend a good amount of time on the main hero, the statins, how they work. After that, we'll see that not all statins are the same. And finally, a nice little cheat sheet for you to use in the clinic. Chalo, let's start.
All right, let's get into it.
The villain of our story, the condition we are trying to fight, is hyperlipidemia. Think of it like this silent bad guy, just quietly causing trouble inside the body. But what is the actual problem? Why is it so dangerous?
You hear this all the time, right? Bad cholesterol, bad cholesterol. We're talking about LDL, of course, low-density lipoprotein. But have you ever stopped to think what actually makes it so bad? I mean, what is it physically doing inside our arteries, our body's pipelines?
Okay, here it is. This is the main issue. All that extra LDL cholesterol, it doesn't just float around. No, it starts sticking to the walls of our arteries, and it builds up, forming these fatty deposits called atheromas. And these atheromas, Bacaccio, are what cause heart attacks and strokes. This is the enemy we are fighting.
So, we've identified the villain. Now, how do we defeat it? Well, luckily for us, we have a whole team of superheroes ready to go. Let's meet them. The 5 major classes of hypolipidemic drugs. Look here. This is our whole armamentarium. You've got HMG-CoA reductase inhibitors, or as everyone calls them, statins. Then there are fibrates, ezetimibe, which is a sterile absorption inhibitor, bile acid sequestrants, and nicotinic acid. They all have their own special powers, but today, we're going to focus on the captain of the team, the real superstar, the statins.
Okay, let's put our main player under the microscope. Statins. I mean, these are the big guns. They're the most effective, the most prescribed, and patients generally handle them very well. But just knowing that isn't enough, right? To be a good doctor, you need to know exactly how they work their magic. So the whole secret to statins is what they target. Think of your liver as a cholesterol-making factory. Now, every factory has a main power switch, right? The one that controls the whole production line. In our liver's factory, that main switch, the rate-limiting step, is this enzyme HMG-CoA reductase. If you can control this switch, you can control how much cholesterol the body makes. And this is how it works. It's a beautiful 3-step process. Step 1, statins go in and just turn off that main switch. They inhibit the HMG-CoA reductase enzyme. Step 2, naturally, the cholesterol factory inside the liver slows right down. But step 3, this is the really clever part. The liver now realizes, hey, I need more cholesterol. So what does it do? It puts out more LDL receptors on its surface and starts grabbing all the bad LDL cholesterol from the blood. Simple, isn't it? Less production inside, more cleaning up outside. All right, so we get the basic strategy now. But think of it like a cricket team. Not every batsman has the same strike rate, right? Same with statins. They're not all created equal. They have different properties, and knowing these differences is what will make you a smart clinician who chooses the right drug for the right patient. So we can basically split the team into 2 squads. First, you have your solid, reliable players, the low to moderate efficacy statins. That's your lovastatin, pravastatin, and simvastatin. And then you have your star players, your heavy hitters, the high efficacy statins that can really smash the LDL levels. I'm talking about atorvastatin and rosuvastatin. Now, this table is full of clinically important stuff. Look at the plasma half-life. Just look at it. Simvastatin, it's in and out in about 2 to 3 hours. But then look at atorvastatin. We're talking 14 to 18 hours. And rosuvastatin, it's working for almost a full day, 18 to 24 hours. This is a massive, massive difference, and it totally changes how we prescribe them. Oh, and also, please note that warning for simvastatin. At the 80 mg dose, there's a higher risk of myopathy or muscle problems. So what are we talking about when we say low to moderate efficacy? In terms of numbers, these statins will bring down the bad LDL cholesterol by about 20 to 45%. Now, that's not bad at all. It's a good result. But sometimes, especially with very high-risk patients, we need more firepower. And this is more firepower. The high-efficacy guys, atorvastatin and rosuvastatin, can bring down LDL by up to 55%. That is a huge reduction. So when you really need to be aggressive with a patient's cholesterol, these are the drugs you reach for. The numbers really tell the story here. Now listen up, because this is a golden point for your clinical practice. Why do we always tell patients to take their statin at night? Well, it's because that cholesterol factory in the liver works the night shift. It's most active at midnight. But remember that long half-life of atorvastatin and rosuvastatin? That changes everything. Because they stick around for so long, they provide round-the-clock coverage. So the patient can take them in the morning, afternoon, whenever. And trust me, that flexibility is a game changer for making sure patients actually take their medicine. Okay, we've spent a lot of time on statins, which is good. But now let's zoom out again and quickly look at the whole gang. all 5 drug classes. This is your quick summary, your cheat sheet for exams, or for when you're on the wards. Okay, let's go through this fast. Statins, undisputed kings of lowering LDL. You see the double down arrow, bile acid sequestrants. They lower LDL too, but look, they can actually increase triglycerides sometimes. Now check out fibrates and nicotinic acid. See the double down arrow next to TG. This tells you that if triglycerides are your main problem, these are your guys. And nicotinic acid, look at that double up arrow for HDL. It's the best for raising good cholesterol. And finally, you have ezetimibe, which works in a totally different way by blocking cholesterol absorption from your food. So, what's the bottom line? If you remember nothing else, remember this. 1. LDL cholesterol is the main target. That's the one we go after. 2. Statins are our #1 weapon to do it. 3. The most powerful statins are atorvastatin and rosuvastatin. They can lower LDL by up to 55%. 4. Because of their long half-life, you can take those 2 any time of day. Super important for patients. And 5. Don't forget, if the main problem is high triglycerides, then you need to think about other drugs, like fibrates. And that leaves us with the big question, doesn't it? The one you'll face every day. You know all these facts now, but how do you actually choose the right drug for your patient? Because it's not just about the numbers. It's about their whole lipid profile, their other diseases, their lifestyle, everything. And that, my friends, is when you move from just knowing pharmacology to practicing the art of medicine. So keep that question in mind. Thank you for your attention.